Hi again. As I stated in the introduction, we are working on the anxiety disorders and the OCD. The biggest challenging part is the resistance to the treatment and also prognostic elements and also the comorbidity. As stated in the DSM-5, OCD is the emerald sheep of a wide spectrum, and there is numerous comorbidities, and of course this is making the treatment more difficult. And new subtypes appear out of this comorbidity. It seems possible. Autism and schizotypy matters. Characteristics. Till DSM-5, schizotypy features were not underlined, but we see that schizotypy and autism features and traits can comorbid along with the OCD, and they will be playing an important role because it's making it gain a new dimension in terms of the treatment process, prognosis and subtype. And in a couple of years of time, we don't have the sufficient proofs yet. Autism, can it be a subtype of an OCD? For example, when you look at the literature, there are some studies, but in order to have, it's far from proving the general picture. OCD and hoarding. This can be seen more frequently in tics, in ADHD and bipolar disorder relationship, and a separate OCD disease. It's a new approach stated in the DSM-5. And in the future, schizotypy and autism are going to be the next ones. Especially the young researchers might be focusing on these fields. We can say that it is necessary. OCD has had great transformations. It's an old disease, and the etiology, the clinic, the phenotype, genotype relations, the co-diagnosis and their response to the treatment. When we look at these criteria, some research groups conducted serious researches about the subtypes of OCD. There are many subtype studies of OCD. The purpose here is to classify the symptoms of OCD, the etiological relationship, the overlapping and comorbidity and prognostic approach. This has the purpose of classifying them in the right fashion. IC10, the obsessions are more prominent than the compulsions, and in some other research, classifying some symptoms and which symptom subgroups differentiates from the others, and we can see that in the core symptoms, and it affects the treatment and the prognosis. These three questions are of great importance. Last but not least, Bloch and et al. They did some factor analysis, some cluster analysis. The autism, and in the framework of autistic spectrum, we can see them, and we are going to be evaluating them in the upcoming periods. We will be sharing the results with you. In OCD, we are talking about specific traits. The tic, for example, it's a trait, and it is definitive as a subgroup. And this has been known for so long, the relationship between the tics and the OCD relation. It might be Tourette syndrome, for example, multiple tics. In the OCD, along with the schizotypy, these are the first two phenomena in the OCD. Now we add up autism and the personality, and personality is a trait now which is accepted to be genetically transferred from OCD, schizophrenia. In all diseases, these traits are differentiating factors for the subgrouping, and they're affecting the treatment and the prognosis. Schizotypy is known and the tic is known commonly. The autism relationship requires new researches, and especially the personality correlation can also be further researched. In OCD, schizophrenia, these are difficult diseases. In the acute period it's different, in the follow-up period different. So OCD can be a repetitive disease, no frequent remission, and the treatment response is around 50% for the treatment of 8 weeks. It's a difficult disease. We all know that there are many factors affecting the negative response to treatment, the obsessions, trauma, childhood trauma, multiple personalities, etc. And I would like to focus on today's subject. Why do we have difficulty in treating OCD? There are some phenomena that we are not knowledgeable about, like the personality traits, the difficulties in personal relations, hoarding, tic, and autistic characteristics. We can skip or we can miss them in the clinic because it might be difficult in OCD patients to notice them. We say difficulty in interpersonal relations. Is it because of autistic characteristics, or maybe they're avoiding, maybe because of the heavy stress or the anxiety? The tic and hoarding are accepted as a classical standard. This is the cluster A traits, and they are like the negative predictors for the treatment. Tic definers, it's in the DSM-5. Tic is quite interesting. Tic, hoarding, and OCD. And ADHD. They do have cross correlations. We are looking at ADHD, OCD, ADHD, bipolar tic, there are cross interactions, and tic is in the center of all of them. And tic disorders, and I presented it last year. In bipolar disorder and ADHD, you can see them with the symptomology. It might be the motor disorders or ritualistic behaviors, when OCD comorbids, and like the symmetric or the counting, etc. These are all about autistic OCD, and autistic patients with OCD symptoms, or the vice versa. They do have the similar symptom cluster. Hoarding, as you all know, it is closely related to the tics. There are more intensive obsessive compulsive symptoms, and autism or autistic traits have hoarding compulsion and the subtype, and they show resistance to the treatment. OCD can be regarded as a cluster disease. The spectrum disorders have been defined, yet there are great difficulties in classifying the subgroups. You can understand it. I wanna skip these parts very fast. There have been a couple of sessions about autism. If you would like to make any contribution, please do, especially pediatric psychiatrists. As you all know, autistic spectrum disorders, they start in the early childhood. There are two main symptom groups: social communication insufficiencies and repetitive behaviors, and spatial fields of interest. Social communicational insufficiencies. These are two main symptom groups. What do they have to do with the OCD? The repetitive behaviors and the fields of interests, These are crossing with the OCD, stereotypical repetitive motor movements, the like for routine or over or under stimulation. Essentially, can we talk about an autistic subgroup in OCD? There are two main issues here. Is there any OCD under OCD, and is there any subgroup of autism in the OCD patients? There should be two questions, but the easiest answer is to have whichever one is the predominant, then the other one is the subgroup. But we do have an hypothesis. When we look at from this way, OCD has very intensive comorbidities, and it's heterogeneous and it's neurodevelopmental. And our first mistake is to miss the autistic traits. This is the first hypothesis. And the second of all, high functionality and the other autism spectrum, maybe they can coexist, and if we can't find anything, we can say that autistic traits are at higher level when compared to the normal patients or the other diseases. We started this study with Behçet Uz, and we looked at the schizotypal traits in the autistic patients. It is around 20% in the OCD, and with the autistic people, the OCD prevalence is around 7 to 35%. Can this person become autistic? We know that most of the OCD patients, they're aloof, they're apathetic, and they avoid relationship. They're cold, they don't like social contacts, and depending on the symptoms, they might be feeling insecure or septic. These might be some traits. This is what we say. Bero, for example, in 2001 stated that among 64 OCD patients, he defined autism but as stated in the article of Bero, the main element is the personality. Paranoid, schizoid, schizotypal, and plus OCD and the other personality traits. These can be indicators to define the autistic dimension. Apart from that, OCD with autistic spectrum, Bero says that it might be high functionality autism. Along with this publication, in some other publications as well, the relationship between the autism and OCD started to attract attention. This table, I took it from Bero article of 2008. You can see many things very clearly, and we can add new variables. In hoarding or in tic, as I stated earlier, these symptom groups are similar to one another, and autistic traits, tic plus pure OCD, and 3 groups were compared in this table. Symmetry, hoarding, these are distinctive elements along with pure OCD. Autistic traits and tics in the symptom breakdown, they are similar to each other. The classical OCD symptom, cleaning and washing hands, it goes down in the pure OCD. Bero, for example, aloof effect, and that feeling distant in the relationships, those feelings, it is more common in the autistic traits. and personality characteristics, as stated by Viero, they are much more important in the autistic spectrum patients. ADHD and tics, they do have very close relationship. All these findings are open to replication, of course. All clinics can provide new data. In OSB, as in OCD, it has a very rich comorbidity. ADHD, of course, pediatric psychiatrists are more knowledgeable in that regard. In the autistic spectrum disorders, that purity, social disassimilation, and it might be mistaken with some other characteristics of ADHD. The anxiety disorders is more than 50% in the autism, and most of them are OCD, tic personality, and eating and psychosis. And it is catatony, it is a definitive, and the obsessional slowdown is a type of catatony, and it is complicating our approach, of course. Is there an OCD subtype in the autistic disorders? There are many studies in that regard in the pediatric and adult psychiatry. It might be ritualistic or stereotypic and repetitive behaviors, especially symmetry or hoarding, repetitive, hitting, etc. These are stereotypical behaviors, and this might be obsessive compulsive subtype, but they're difficult to differentiate. Is it because of the OCD or is it because of the autism? How are we going to differentiate them? First of all, the rituals in OCD are egocentric. If there is a ritual in OCD, anxiety, dysphoria, we don't see them. In such ritual, might increase the anxiety, and we need to be careful. In ADHD, there might be a function of that, and this emotional loading maybe can decrease the anxiety, and they might be preventive for the threatening emotions, and they might be relieving. And in the autistic individuals, there might be more compulsion, and they might decrease in the adolescence. And there is new concept, thought action fusion. The connection along with the obsessive compulsive content, emotional experiences, and the other one, they're not meaningful connections. Surreactive obsession, and they do have the connection, and they're making them an emotional reaction, and they're living it, and they're trying to cope with that. But in autism, this, along with these obsessions and the compulsions, there is no reasonable connection between the content and the emotions. There are some functions of the compulsive symptoms, idiosyncratic stereotypes from simple reflexes to complex behavioral patterns in autism. Therefore, it's a way of self-organizing, and the autistic people know that as they are not accepted in the society, they try doing that alone. The most difficult part is the hoarding. Because of the special fields of interest, they hoarding. And there might be symmetry or the other one. And there might be some other interactions, the family relations, the educational styles, and they might be effective in both groups. Again, in the autistic behaviors and in OCD, they might be affecting the same brain regions. OCD is a biological and neurodevelopmental disease. It might be either in the old age or the early ages. The traumas or Parkinson's disease or basal ganglia diseases, OCD can appear at all ages. Therefore, OCD can start neurodevelopmentally early starting disease, and it's a chronic disease. And in OCD, they do have the common brain zones, and information processing in OCD and ASD. There are local information processes and also the global information processing orders, and in both diseases local information processing is more dominant. They are focusing on single elements and their rituals, and then they develop quite narrow fields of interest, and they are trying to have some control over such events, and they are looking at the capacity on the local events.
This deteriorates in executive functions. The response which is found is that the signals that should come from central system is lacking in OCD. Therefore, there are these extreme behaviors. This endophenotype could be related to these extreme and repetitive behaviors. Amygdala is very important in autism. They are lacking in automatic behaviors in OCD. In autism, the external stressors could trigger this, and when the stress factors are not taken away, panic, anxiety, and dysphoria stress feelings are experienced, and neuroanatomic and neurologic mapping in cortical pathways. There could be the functional dysfunctions, depressions, the strict, rigid behaviors or repetitive behaviors could, and this is related to the direct and indirect pathways. Good management of the behaviors, not suppressing the behaviors, can be observed, and there are processes that even the memory system can be affected by this. As you know, there are two neurotransmitters in OCD. Its role is enlightened. We see it in fMRI rat studies and also drug trials in biological. There is the serotonergic and dopaminergic medications should be administered. So when the comorbidity increases, the schizotypal threats and the antipsychotics are effective in OCD and also autism and also tics. And in mesolimbic system, in mesocortical levels, dopamine antibodies have a role in both disorders. So there are some interesting genetic studies. The autistic families, OCD could show genetic predisposition for autism compared to normal controls. Motor tics, OCD symptoms, anxiety disorders, and depression are more observed in the autistic families, and there's a relationship with the repetitive behaviors of the autistic child and the anxiety of the OCD of the parents. There are biomarkers, and this could show a transition among the relatives, and there's an endotype for that, and there are such relationships. The genetic studies show this. However, their number is very low, and when we consider the number of cases, autism and how there is the OCD symptoms turn into obsession and OCD, and with the age it might be different. For example, collection behavior could turn into a collector's behavior. You know, there could be OCD is specific collection behavior, and in this they might turn into attractive behavior. So they there could be fears to obsessive fears based on the interest areas of there are chart that she's going to talk about, but schizotypy is a historic concept. It's been discussed. Schizotype, OCD, whether there is present or not, schizotypal behaviors. Autism can be in later DSM, but schizotypy could be an early subtype, and for there are qualified publications in the literature regarding this. In OCD, we see measure if there are weird behaviors, weird beliefs, if there are present, if there's a feeling of loneliness, or you know, there could be doubt related OCD. Like this is this is a threat for OCD. Actually, there could be one of the common in the markers or indicators is that if you consider an OCD patient from this angle, there are some important tests developed for autism, for OCD, and they are very commonly used. And schizotypy, it is possible to see them, even if that person is not schizophrenic. There could be hallucinative or delusional OCD, and it is again an important indicator for the treatment. It's an important subtype candidate. Could you please wrap up, sir? Please, I will wrap up. Schizophrenia, OCD relations, the OCD symptoms, like the magical ideas, are related to treatment mode, and the peer relations and family relations and academic life, there could be important problems experienced by the patient. What we are going to tell here is show an early onset of OCD. There are some biological data regarding antipsychotics. The attention should be paid, and OCD symptoms are more common in the relatives. Collection and cumulative behaviors. There is a cluster. It is like collecting certain things. It could be seen as a subtype. But there could be magic and mystic behaviors, and experiencing this and being under the influence of this dysphoria and anxiety could be observed. Again, repetitive unlogical sentences repetition. There is a magic, and there is interpretations with mysticism. The OCD patients can be understood. There is autogenous obsessions, but it's more associated with this schizotypal behaviors. For example, a letter or a digit could mean that he should attack his sister or brother. There could be such obsessions, and there are reactive obsessions. Reactive obsessions are more common in OCD patients. Anxiety arising, obsessions, autogenes and reaction differentiation is like that, and there's the behavior and action fusion. It is very important in schizotypal. In schizotypal OCD, we see that there are important publications, 1 or 2 publications. It means interpretation of the factors, external factors with bias. If there could be a differentiation based on the logic, whether it's logical or not. There is a moral type. In moral type, we see it in sexual and religious obsession. Some unacceptable stimulus cause a dysphoria in the patient. If there is, for example, a sexual obsession could be very severe for a religious person. It could cause anxiety and a feeling of guilt, we know of, and they have an anxiety of whether the chances are increasing or not for happening. It is like, what if what I am thinking will be realized in the normal life? So it causes these feelings, it causes anxiety, and it also gives us schizotypal features in normal OCD. Of course, behavioral treatments are very important. SSRI and antipsychotic administration would be more appropriate. And for resistant OCD, neoadjuvant treatments could be given, and BDT has an important role in this regard. I hope I have been understandable.